was fantastic today. Beautiful slides. I'm going to nick some of them from you if you don't mind. What a wonderful way to introduce the clinical approach to thyroid cancer. Our next speaker is Dr. Geoff Schembri, Senior Staff Specialist in Nuclear Medicine at our hospital. He's been involved with a large range of research optimising lung imaging for pulmonary emboli, the role of PSMA in initial staging and restaging of prostate cancer, and the use of PET imaging in the diagnosis and management of glioma. Therapy has become an increasing part of his clinical practice, including iodine for thyroid cancer and also lutetium-based therapies for neuroendocrine tumours. Geoff Schembri, thank you.
Thank you. And I'm going to apologise if I cough. I've had the bug, but recovering. So thyroid cancer, where are we going with therapy? I'm sort of going to try and take you through a bit of a cook's tour of nuclear medicine and therapy, and hopefully give you a better understanding of what we're about. So everything starts on an evening with a good fairy's tale. So once upon a time, if you had a broken leg, they put it in a cast. And if you had breast cancer, you had mastectomy. And so there was one treatment, and that's what you got. Because if someone ate your leg, there wasn't quite as much as we could do for you. Now, if you voted for Trump, then you had to have a frontal lobotomy. Or maybe I've got that backwards. So, things have changed, and now we have a lot more options available to us. Sure, you might still get that cast, but there are other ways of fixing broken legs, from nails to plates to rather more extravagant bits of surgery. And for breast cancer, sure, mastectomy is still there, but there's lumpectomy and radiotherapy and chemotherapy and hormone therapy and immunotherapy. So there's now multiple options available to us, and what we need to do is try and pick which of those is the appropriate treatment for the appropriate patient. So why is this all changing? What's happening? There's a whole range of new classes of drugs that are becoming available to us. We're characterising tumours much better, and you may hear this word genomics. We're now looking at the DNA structure of tumours. And the interesting thing we're learning is that not all tumours are the same. Just because you have breast cancer doesn't mean that your breast cancer is exactly the same as somebody else's breast cancer. And indeed, one treatment that works perfectly well for one subtype of breast cancer may be completely useless in another. And so we need to identify a bit more carefully what we are treating. And that means that we can target the therapy and hopefully get a much more specific response to the therapy that we give. Now, thyroid cancer, radioiodine therapy has been around for a long time, and you may have seen the buzzword theranostic. Theranostic means an agent that we can use for both therapy and diagnosis, and indeed iodine was the very first of this. It was an agent we used to scan thyroids to find problems, but it was also an agent that we could use to treat thyroid cancer and other thyroid diseases. It's been around since 1941. And as Di alluded to, really, you pretty much got hit with a sledgehammer. In fact, we did have two sledgehammers. We had the medium sledgehammer and the heavy sledgehammer. And we just used one depending upon whether we thought you had disease in the thyroid or whether the disease had already spread. But it was pretty basic stuff. But hang on a sec. What is radioiodine anyway, before we even get to talking about how we use it? All elements in nature exist in various isotopes. So you have isotopes of carbon and other atoms. The good thing about isotopes is it's exactly the same chemically as a normal element, except usually it has more neutrons. And what that means is we can actually use an isotope and it will behave just like the normal element, but we have changed it so that we can either use it for treatment or for taking pictures, seeing where it goes. Usually the isotopes are radioactive because they've got too many or too few neutrons, and they release radiation, and that allows them to change their atomic number and become a bit more stable. These are three of my favourite elements, and they form one of my favourite compounds. So when we talk about radiation, there's three typical forms of radiation that we deal with. So there's gamma radiation. So gamma radiation are gamma rays or X-rays when they're produced artificially. Beta radiation, which is simply an electron being released from the atom. and alpha radiation, which is actually a whole helium nucleus, so it's 2 protons and 2 neutrons. So all of these are what we call ionizing radiation. What that means is as they pass through your tissues, they ionize the material in your cells. And it's that ionization is what causes the damage that it will eventually lead to cell death. Now, the bigger the particle, the more damage it does, and the less distance it can travel in tissues. So that means gamma radiation, which in fact is not a particle at all, has very long range. So as we all sit here in this room, we have gamma radiation passing through us. And through most of the time, it's not stopping. It's just going straight through and on, and probably won't interact until it gets many light years away from here. So we use that in our imaging. Now, beta radiation is a much shorter range. It's a couple of millimetres, and so you can target reasonably well with using beta emitters. And alpha give very high energy almost exactly at the source of origin. So it's very good for targeting, but it does do a lot of local damage. Radioactive iodine is both a beta and a gamma emitter. So we use the gamma for taking the pictures and the beta for the therapy. Now, thyroid takes up iodine. In fact, it uses that iodine to make the thyroid hormones, and that's stored in the gland. Fortunately for us, many of the tumours also still take up iodine, so what we call iodine-avid tumours. And that means we can give this isotope of iodine and target them with the radiation and hopefully destroy the tumour cells. But hang on, radiation, is that safe? Well, I think it's safe. I've been working with radiation all my life, and sure, I used to be 6 foot tall and have hair. But as far as I can tell, it's had no adverse effects whatsoever. So we live in a world that is full of radiation. And some people would like to make it more full of it. Our bodies are perfectly adapted to a low radiation environment. But high levels can certainly overwhelm repair processes, and that's what we rely on when we're treating cancer. So we try and overwhelm the cancer and minimise the injury to normal tissues. By the way, you do know this is just steam, right? I was put those photos in there. It looks pretty scary. So as Di showed you, radioactive iodine, we get scans that have this kind of appearance. And you can see that you get uptake in salivary glands, in the stomach, in the bowel. You get excreted through the urine, so it's in your bladder. So you might think, well, when we're treating someone with radioactive iodine, are we going to damage all these other structures as well? Certainly salivary damage is a potential complication. Luckily for us, most of the other things there are pretty resistant to radiation, and it's very rare that we'll see any issues with that. Other things we need to be aware of are cancer induction and fertility. So let's talk a bit about salivary glands. Salivary gland problems are the most common problem of radioactive iodine therapy. Up to half the people that we give radioactive iodine will get some symptoms in the first 12 months. Not sure if Amber got any, but she's nodding her head over there, so I think she did. So that's usually pain or swelling, a dry mouth, altered taste. And about 16% of patients will still have symptoms at 5 years. So this is a real complication and something we'd like to minimise. One thing that is definitely shown, the more you give, the higher the chance you'll get salivary gland problems. So here's one good reason to try and give less radiation if we can. Secondary cancers. Now, even if I don't give you radioactive iodine, there is an association between having one type of cancer and other types of cancers regardless. So you have to correct for that effect when you're trying to decide if there's a genuine effect from the radiation. However, while there is some mixed data, I think that we're pretty happy that there is some increased risk. One study said that the risk was only there when you had lots and lots of doses, so up to 37 gigabecquerels. A standard dose that we give is between 1 and 4. One study that looked at breast cancer in particular showed no increased risk of breast cancer. That was good news. But certainly it does appear to be some slight increase across a range of cancers, though again, not with single dose therapy, but once you get to multiple dose therapies. And almost all of these show a dose response. The more you give, the higher the risk. So again, a good reason for trying to minimise the dose. What about fertility? Well, for men, you can get a transient reduction in sperm for up to 18 months. Permanent infertility almost never occurs, and there's very little effect just from a single dose. In women, you can get transient amenorrhea in about a quarter. It can bring on menopause a little bit earlier than normal. And we normally recommend that you delay pregnancy for about 6 months. That's not because of the radiation per se, that's because if you need a second dose, we don't want you to be pregnant and unable to give you the treatment that you need. So why are we going to give it? So there's a couple of reasons why we might like to give it. Managing cancers is often easiest when you have a marker for that cancer. So for prostate, we have PSA as our marker. For thyroid cancer, we use thyroglobulin, which is a protein produced by the thyroid glands. Now, in a perfect world, you would hope the surgeon would take out the whole thyroid gland. But even the best surgeons, even Mark, can't get all of the thyroid out because sometimes there's these nerves, and patients like to talk after the surgery, and there are blood vessels in that area. And sometimes not all the thyroid's exactly where it's meant to be, but there are little remnants left around. So you just can't get all of it in every single person. So reason one, we give radioactive iodine to complete the surgery, to get rid of leftover normal thyroid tissue. So we're not thinking this person's got cancer, we're just cleaning up, and that allows us now to use thyroglobulin as a tumour marker. Now, the alternate scenario is where we didn't get all the cancer, and we'll go through some of the things that make us think that, but bits of cancer may be left in the thyroid bed or in lymph nodes or in distant sites. And in some patients, it can be in the lungs, and in others occasionally in the bone. So if you have residual cancer, there has been studies that shown giving radioactive iodine will improve your survival and reduce the risk of local recurrence, of the cancer coming back locally. So if we think you have cancer, then we will give you radioactive iodine to improve your long-term outcome. So as we sort of already covered a bit tonight, we now know that not all cancers will benefit the same. In fact, many of them do perfectly well with no treatment, and low-risk cancers do not need radioactive iodine. So how do we know who needs it and who doesn't need it? Well, this is not Anthony Gill. We try and categorise the cancer into groups of low, intermediate and high risk, and we do that by looking at the histology, what kind of cells are in there. We look at where those cells are found. Have they spread outside the thyroid into vessels, into lymph nodes or lymph vessels? And we look at the genetics. And occasionally we'll even talk to the patient. The patients will often have an opinion. Some of them will want therapy. They go, I don't care, I just want to have it. And others are terrified of having radioactive iodine therapy. And we have to balance their concerns when we're deciding what we're going to give them. Are they young? Are they old? Have they got other issues that we need to be aware of with their health or their families? What's their straightforward preference? The thyroglobulin level, the higher the level is post-surgery, the higher the chance they might recur. So in my head, whenever I speak to the patients, I try and form the question and answer the question, do I think they've got residual cancer? Yes, they need this dose. Am I just cleaning up any leftover thyroid tissue? Yes, they need this dose. Are they low risk? They don't need anything. Why they get sent to me? Okay. And the same side as Di, so I'll skip that one. Now, we know that there's some risk of therapy. We know that risk does have some linearity with dose, so the higher the dose, the higher the risk. And therefore, we want to try and give low doses to some people and high doses maybe to others. So we're going for the Goldilocks effects here. We want to get it just right. So the two trials... Will Emily Hibbert stop coming? Go away, Hibbert. So the two studies, there's the HILO trial. And this was quite interesting because two trials came out in 2012. One was from the Brits and one was from the French, and so there was all sorts of fun at the meetings with those two groups. And what did they find? Look, they looked at low rates and they compared a 1 gig dose to a 4 gig dose effectively, and they showed essentially there was very little difference. So if all you're worried about is getting rid of thyroid tissue, you can do that effectively with 1 gigabecquerel. And that has a few benefits, not just from the lower radiation. The patient needs to stay in hospital less. They can go home the next day. So that's actually a benefit for the cost to us as healthcare providers, but also to the patients. So we know that some cancers are cured by the surgery. They don't need any other treatment. The low-risk ones, as we've sort of already discussed, these are the small solitary cancers, no nodes, or small, with some lymph nodes, but not too much lymph node involvement. If it's multifocal, but they're all tiny. then we would not recommend routine radioactive iodine ablation in these patients. And if someone really, really wants something done, then we'll give that low-dose therapy. And there's no evidence of benefit of radioiodine in this group. What about the intermediate risk group? So we've already sort of covered a little bit about what makes these things more intermediate, but it's pretty obvious. It's when they've started to spread, either directly or through significant nodal involvement, or they've got those more aggressive subtypes, or they've got the mutation. Then I think we would mostly say, okay, well, we're happy to give them radioactive ablation, iodine, and there is certainly some evidence to show these patients will have improved survival if you do that. And if we're not too worried, they might get a low dose. If we're a bit more worried, we might give them a 4 gig dose. Look, high risk, definitely I think all of us here would probably agree they need cancer. Therapy, I'm not going to go through all the things, but there's definitely, I think, evidence to show that they will get some benefit in general from treatment. Now here at North Shore, for nuclear medicine, we treat about 150 patients a year, so that means out of the 250, 300 patients getting cancer, only about half of them are coming to us for treatment. Just to show we are doing some improvement. In 2011, 25% were getting low dose. Now we're up to nearly 40%, and 55% were getting high dose, and that's come down to about 40%. So we're shifting, but maybe we haven't shifted quite as quickly as we should. So that's all I was going to talk about today. And